I'm going to talk about instability, shoulder instability in particular. The shoulder is a very loose joint by its very nature. Many times we think of the shoulder as a small hip. A hip it is not. The hip, which is much like a soup bowl with a ball that fits inside of it, has much more constraint. We must think of the shoulder more as a golf ball on a golf tee. Because of that, the rotator cuff, the capsule, the surrounding structures to include the labrum play a large role in the stability of that joint. If you're having instability, generally it's a breakdown either with the capsule or the labrum. The labrum acts as an O-ring that surrounds the socket and helps to provide support against shear forces in the joint. When the labrum tears, many times we will lose one of those mechanisms and can then have instability issues. Instability can be anterior, which is most common, posterior, or multidirectional. When a patient has an unstable shoulder and has MRI documented changes such as a labral tear, many times it requires surgery. When we review an MRI and it shows that the labrum is peeled away from its normal position, many times we talk about surgery to reposition that labrum and hence restabilize the shoulder. If you get to the point that you need instability surgery, this is what you would expect. The surgery is generally performed arthroscopically. That means through tiny poke holes about the shoulder, we insert instruments to include a camera and various grasping type devices. Through these small poke holes, we're able to perform a surgery to stabilize the labrum to its normal position, generally using anchors, which are small devices that countersink inside the glenoid or the bony aspect of the socket so that we can then tie the labrum back to its normal position. Preoperatively, we generally have you see your primary care doctor for medical clearance. That includes having an EKG, chest x-ray, and various labs performed. Many times the reason for this is to make sure that the anesthesiologist is comfortable putting you to sleep, as this surgery requires you to be under a general anesthetic. The risks of the surgery can include continued instability, infection, need for further surgery, and even death. Because it's under a general anesthetic, these complications can exist, and because sometimes we don't know what the quality of your tissue, particularly in those situations where you've had chronic instability for some time, the need for further surgery can sometimes arise. We generally know more after your surgery is complete and we've had a chance to actually grasp and manipulate your tissue at the time of surgery when we're stabilizing the labrum to the glenoid rim. On the day of surgery, you can expect to have to get to the hospital between an hour and a half and 2 hours prior to your surgery time. This sometimes is a little bit different from one hospital to the next, depending on what their normal protocol is. When you arrive, they will get you prepared for surgery, such as getting you into a gown. You'll meet the anesthesiologist. I will come shortly before the surgery and mark the operative side so that we know exactly which side we're fixing once you're asleep. Many times the anesthesiologist will also talk to you about an interscalene block, which is a block that they provide at the top of the shoulder that numbs the entire arm. I sometimes tell patients it's much like times that you've fallen asleep on your arm and when you wake up it feels numb or dead. This is temporary and it does help the anesthesiologist decrease your need for narcotic pain medications during the surgery, and therefore you generally have less nausea and an easier time getting home from an outpatient procedure. We then take you to the operating room after you have been through the preoperative process of getting the block and preoperative antibiotics. In the operating room, we perform the stabilization. You're then going to be in the recovery room for anywhere between an hour and a half before you're ready to go home. We'll make sure that your pains are controlled and your stomach is settled before you leave. Once you get home, you'll notice that you may be in a brace similar to this Ultra Sling. This brace has a strap that goes around your waist as well as over your shoulder. It has a pillow that keeps your arm in a comfortable position. With most instability surgeries, you're going to be in a brace like this all the time except when bathing for about 4 weeks. When you get home, generally there'll be a dressing on the shoulder. I generally leave the dressing in place for 2 days. After that 2 days, you can remove the dressing and begin showering. It's also important to remember when you get home to make sure that you keep the shoulder iced, particularly in the first 48 hours. We send you home with pain medications so that we can make sure that we keep your pain controlled with oral medications after surgery. Most people require them for the first 48 hours, and then from one person to the next it can change depending on your need for medication and how extensive your surgery was. As we move on, as I previously stated, you'll spend about 4 weeks in the brace. After we get you out of the brace, some general guidelines are this. The ensuing 4 to 6 weeks generally have you perform gentle, passive range of motion exercises to start loosening the shoulder. We generally start strengthening exercises no sooner than approximately 12 weeks following surgery. These are generally light and we progress slowly. Contact sports are generally no sooner than 6 months following an instability surgery. Well, I hope this answers any of your questions you have about the possibility of an upcoming instability surgery. Should you have further questions, please feel free to call us at any time. Thank you.